Part 2 of musculoskeletal injuries, we'll start off with standard precautions. So assume all trauma patients have open wounds. You don't want to, get on scene and then look, oh, they're bleeding, I have to put my gloves on. You already have them on. And that's the easiest way to think about that. If you respond to a motor vehicle crash, make sure you have more than just gloves on because of the possibility of glass and metal that can cut you. If they have active bleeding that may splatter, then you want to think about protection for your eyes, nose, and mouth, like a face shield with the mask, maybe even a gown. So some things like that you need to think about for standard precautions. Examination of musculoskeletal injuries really starts at time of dispatch, right? But when you walk in, you get that general assessment. You could get a call to a basketball court and somebody's sitting on the ground with their leg flexed and they're holding their knee. You're like, oh, he's got a knee injury. You could go to a motor vehicle crash and, they're holding their right side where, they wiped out and maybe injured their hip or their femur or something like that. So, that general impression kind of gives you some information. Most of the time, limb injuries are not life-threatening, not unless there's excessive bleeding, but they could be limb-threatening, meaning that if there's compromise of the nerves or, a severely mangled extremity, they could lose that limb. So it may not be life-threatening, but it could be limb-threatening. So think about the patient's ABCs first. Don't let those injuries distract you. And the reason I point that out is if you go to a motor vehicle crash and there's 4 patients, and there's one laying there with this grossly deformed arm, like the arm is facing the other direction, and she's screaming at you, please help me, please help me. And there's somebody else over there laying not too far from her who's not screaming at all. And they've got the head injury, and they're unconscious from the head injury and barely breathing, and you're going to look at that lady's arm and go, wow, that looks really... No, it's a distracting injury. The fact that she's awake and screaming at you, she's got an airway, she's breathing, she must have a pulse, move to the one who's not moving. Because if you take care of her, then the other one stops breathing, you could lose a patient. So that's why I always talk about, distracting injuries. They tend to be that way. But examine it. Compare it to the other side. Ankles, knees, wrist. Let me see that one. Let me see what your normal one looks like. Now there's a chance they could have bilateral injuries. They jumped off of something, broke both their ankles. But the chances they broke them all the same way would be, not real common. Look for those other things that we talked about. Is it painful? Is it swollen? And does it have deformity? So touch it. Tenderness is the best indicator of an underlying fracture. As you touch it, they go, ow, that hurts. And it's almost, we call it point tenderness. It hurts right there. So just like we did our patient assessment, we're going to touch and feel our patients so that we can get them to grimace if they appear to be unresponsive, or they tell you, ow, that hurts. We like that hands-on examination. And as we do it, we say, where does it hurt? Where does it hurt the most? Where does it hurt at all? Localization of greatest pain is probably that injury site. For instance, if you take your finger and touch someplace that you have a bone, like on the radius, not a whole lot of fat there, and then they go, ow, it hurts right there. It may be a non-displaced fracture, no deformity, but could be what we call a hairline fracture. Again, we're not diagnosing, we say possible. We want to evaluate what we call distal functions. So as I think about somebody maybe that fell and they have a little bit of tenderness and swelling to that, maybe the radius on the forearm. And I say, okay, well, I want to see how well the nerves are still working in that area and how well the blood is still flowing in that area. So what I would have them do is, can you wiggle your fingers? Can you feel me touching you, the sensation? And then I would check for a pulse distal, away from the point of attachment, further away from the heart in that extremity, or cap refill even. But I do something to evaluate what we call PMS, pulse, motor, and sensory. And I want to check it in all extremities that I think there could be a problem. I want to check it before I splint, and I want to check it after I splint, and I want to check it in the ongoing assessment to make sure nothing changed. So we've got a skill drill coming up in the lab that we'll do along with our joint and our long bone injuries, checking what we call PMS. All limb injuries are going to be treated the same way. If it's open, we dress and bandage. We're going to make sure we get good pressure on there, but not so much that we create a tourniquet. We're going to ice it. We're going to splint the injured limb. Ice is great. So those chemical you hit them and shake them together, and they're really cold, and that's going to reduce the swelling as well as some of the pain until they can get to the hospital and get some pain medications. So why splint it all? Well, the more that those bone ends move, the more damage there is internally to the soft tissue. And if there's damaged soft tissues, there's going to be more bleeding. So splinting stops all of that. It decreases the risk of additional damage. So that's a big thing. Here's the big one, though. What if somebody had a closed fracture and they said, I'm okay, I just want to hold it myself, I don't want to splint, and then that arm continues to move, and those bone ends that are broken are very sharp, and they rub on the skin until now they're bleeding. Oh, wait, that closed fracture became an open fracture because we allowed it to move. So that's why we splint. There's some rules for splinting. And a big thing with it is remove clothing, remove rings, remove watches, remove things like that that could get in the way or could cause some problems. Look at PMS, pulse, motor, sensory, and record it. You don't want to have somebody that say, oh yeah, I can move everything, and then after they put the splint on, I couldn't feel my hand. We want to keep checking on that. Try not to move the patient before splinting unless there's immediate danger. We actually had a young kid that was hit by a car. He was riding a moped, and he broke his femur and landed in a huge pile of ants. So he was being stung. We had to actually move him with that broken femur just to get him away from the ants. So sometimes that happens. We want to immobilize a joint above and below. So think of this. If it's a joint, like picture an elbow is injured, we want to mobilize the long bones below, which would be the radius ulna, and the long bone above, which would be the humerus. We want to always immobilize joints or bones above and below. If it's a radius ulna, they broke their forearm, or a suspected, possible fracture, I want to immobilize the joint below, which would be the wrist, and the joint above, which would be the elbow. So you see some people, they'll have a wrist fracture, and then they'll end up with this large cast on their arm. You're like, wow, you got all that for a wrist? Well, they have to immobilize the hand and the forearm. If it's a knee, it has to be the lower bones, which would be the tibia and fibula, and then the femur. You have to immobilize all of that. You'll practice this in lab, and I think it'll make more sense to you then. And one thing about wrapping is make sure you wrap tight. The roller bandages that you use or the cravats that you use to hold them in place, your choice. We'll show you a couple of different ways. We try to keep it very simple, not, show you Paula Kay's way and Lawrence's way and Susie's way and, all these different instructors' ways. If you, come up with what works. If it follows the rules and it works, that's good. But if you don't wrap tight, that's not immobilizing. You've got to, stretch that Curlex or the roller bandage around, wrap it nice and tight. If it's a rigid splint, make sure you pad. A lot of the rigid splints come with their own padding. You're going to practice on each other in class where you don't have any broken bones. And then you're going to go out in the field and go, wow, this doesn't look anything like what we practice. Well, no, because they have deformities. And what it means by padding is if they have a place that doesn't touch the splint, pad between there. So it gives it nice, good support the whole time. You can splint the arm without moving it, and that's good. And when in doubt, splint it. I'm not sure if it's a sprain or a strain or splint it. Some materials that can be used. You can use rigid splints. And when you use this, you want to make sure that you cover the injured extremity. And common types of this are padded board splints. I like these because they are reusable. They're covered kind of in a vinyl material that you can wipe off. You can decontaminate them and reuse them again. Molded plastic or aluminum splints, padded wire or ladder splints. I love wire ladder splints, but I tend to be the only one. The disadvantage of a padded wire ladder splint is that you can't x-ray through it. Anything that's metal you can't x-ray through. So we have like the SAM splints that are very moldable. Those are good. You can x-ray through it. So when they're sitting in the ER getting their x-rays, they don't have to be unsplinted for this to happen. Cardboard splints are good too. They just tend to be kind of blocky, square, so you have to do a lot of extra padding. So it shows you a nice cardboard splint on the left, and they would pad all those little voids in there. And then the SAM splint, which is very moldable, and most people have gone to using these. They're nice and compact. You can carry them in your bag. Pretty easy. Soft splints. Now we're going to talk about air splints that nobody uses anymore. I grew up with air splints, and we put them on each other in class. We're like, man, they actually kind of feel good. So it's a kind of a clear plastic splint. You wrap it around the arm, zip it up, and then with your mouth, okay, so next call somebody else's mouth, right? You blow up the air splint, and they really work good. The thing is, almost everything that you use, it needs to be disposable because you're not going to wait around like you do for some expensive equipment when you transport. Bye-bye, bye air splint, you're never going to see it again. One thing about air pressure, though, if you're in a warm environment when you put on the splint and then you move into a cool environment, that air pressure is going to decrease. Whereas if you're in a cool environment and then that patient moves to a warm environment, that air is going to increase and put more pressure on it, maybe even cut off circulation. So you have to be careful with air splints. The soft splint that I like the most is a pillow. Pillows work great for ankles, sometimes arms. I mean, when you're practicing, you take the shoe off. Always take the shoe off. I'll take the sock and kind of cut the toe part away, and then leave the sock on for padding. And I can check distal functions on the toe by checking cap refill and everything. But that pillow splint actually kind of feels good. Traction splints are reserved for mid-femur fracture, so that thigh bone that is injured, a mid-femur fracture, not an upper, not one near the knee, but right there in the middle. And I used to think it was, by pulling traction, we were kind of lining those bones back up. But along with that femur being the strongest bone in the body, some of the strongest musculoskeletal muscles of the body are going to be the quadriceps. And so when that leg is abruptly shortened, like it is when it's fractured, that leg on the injured side will be shorter than the one on the left. That's a classic sign that they have a femur fracture. And those muscles will start to spasm, and that's what creates a lot of their pain. So by pulling traction, you're taking those muscles, the quadriceps, and you're stretching them back out. You're not aligning the bones, you're just taking that pain away. And the traction splint allows you to do that. That's a two-person skill. We don't do it in this class. We do it at the EMT level. And this is one that you have to practice a lot because you're not going to do it very often. Shoulder injury. So if they have what we call an adducted, two types of shoulder injuries. Abducted, where the arm is moved away from the body. Abducted like a child abduction. Or adducted, ADD, adducted, added to the body. So these are adducted shoulder injuries. We make a nice sling, and then we make a swath to go around the top of it. Because remember, in a shoulder injury, we have to immobilize then the clavicle as well as the humerus. The collarbone and the upper arm bone need to be immobilized to immobilize that shoulder injury. Bones above and below. Keep the fingers out so you can check distal functions. It makes a nice splint. And the cool thing about these is if they don't have to go by ambulance now. Somebody can drive them to the hospital. We call POV, privately owned vehicle. If it's just an isolated injury, they don't have any other medical problems, they could go by car. Same thing for a shoulder dislocation. The ones that are abducted, you may have to place a rolled blanket or something between that upper arm and the chest wall because it's out a little bit. Sometimes that'll happen. And then the sling and swath to hold it together. Elbow injuries, we like to immobilize in most injuries. We immobilize them in the position found. You don't take them and let me move it this way. It looks like it'll feel better. It doesn't. But the one injury site that you cannot move is the elbow. If it's dislocated, there's a nerve that can catch in that little joint, for lack of a better thing, but it's kind of sensitive there. And if it dislocates and then pops back in and catches that nerve, it cuts off that nerve altogether, and that person will have like a frozen hand, whatever position that hand is in, it will be frozen in that position. That's why when you're in splinting lab, we'll talk about position of function, which is kind of like a C shape of the fingers and thumb, because you can do a lot. You can put a pencil between your fingers and write. You can wave to people. You can drive a car. But just having your hand flat, and if it froze in that position, all they could do is come back and karate chop you. If you made their hand into a fist, then all they could do is come back and punch you. So this is a nice start for an elbow injury. Look at this one. I'm going to give you a second. Tell me what's wrong with this splint. It's a nice pillow wrap. Pillows are nice, soft padding, and then they've tied cravats around it. But why is this splint not done? So if you look at it, they immobilized the elbow, and they immobilized the bones below, radius and ulna, but they did not immobilize the bones above. So what they would need to complete this is a sling. And I always say, if you use a sling, you will use a swath. Nobody ever got in trouble for splinting too much, but you get in trouble for not splinting enough. Forearm injuries, so you can use an air splint or cardboard splint or a SAM splint. SAM splints are nice because they're moldable to those injuries. So all the deformities that they have, you can kind of fill those gaps in, and we'll do that in lab. And I'll let you kind of read through here how to use an air splint. If your service uses them, by all means, that's what you should use. I like air splints. They also make, what are they called? There's an air mattress, and you actually pull the air out of it, and then they make individual little, smaller, like little, I can't think of the word for it, splints, whatever they're called. They're kind of like little styrofoam beads in them. And when you suck the air out, then it molds around it. They're very comfortable, but again, you send them to the hospital with those, and you're like, you're never going to get it back. So, hand, wrist, and fingers, you can use a short splint just to place the forearm on it. If there's wounds, make sure you dress and bandage those ahead of time. Make sure you place that hand in the position of function. And then attach the arm to the board or the SAM splint or whatever it is, usually soft roller bandage or cravats. It threw in here a little thing on amputated parts, so if you do have any, make sure they go with that patient, and we put them in a sealed plastic bag. Make sure you label the bag. They may get to a major hospital where they have, 4 arm amputations coming at the same time, so I want to make sure the patient gets the right arm. Pelvic fractures. When you're assessing the pelvis, you grab either side of what we call the iliac bones, those top bookend kind of bones. And first we're going to squeeze in, compress in, and then push straight back. You're going to just kind of tilt it at the same time so there's no rocking, pushing in and then pushing straight down. And we'll do this on each other to see that there's no fractures in pelvis. One thing about the fractured pelvis is a lot of times they'll be at the pubic symphysis or posteriorly, and if that happens, there's no support if you log roll that patient. So if you roll them to their side, it will cause further injury. So we don't log roll what we call unstable pelvises. Hip injuries, so it includes pelvis and that upper femur, or it's that fourth one down. Fractures occur in elderly persons because those bones weaken, and it's actually an upper femur fracture. That's why we don't put traction splints on upper femurs, just mid-shaft femurs. Most common thing with hip injuries are dislocation and fractures, and it takes a lot of lot of trauma in the younger people to create those fractures in the pelvis. A lot of times, all you can do is slide them onto a backboard and use pillows and roll blankets. They make pelvic binders now, which are very good, and those kind of compress everything. Because I have to tell you this, femurs, each femur, since it's such a thick bone and has a lot of soft tissue there, can lose up to a liter of blood. And the hips can also lose, pelvic injury can also lose 2 liters of blood. So they can have a lot of internal bleeding from pelvic and hip fractures, and that's why we try to kind of compress them with like a pelvic binder or something like that that keeps them immobilized a little bit better than just the backboard. We talked a little bit about the femur. If it's fractured, it's going to be very unstable. These are the ones you would call an ambulance for. Make sure that a EMS puts the traction splint on. And you can't put them on bilateral fractured femurs, just one side. And we may practice this in class. You're not tested on application of the traction splint at the EMR level. Or this may be an ICE class, so you can kind of see how it's done. And it just kind of shows stabilization. If I ask you, what's wrong with this picture? Well, number one, he's still got his sock on. I at least want to expose the toes. Number two, he's got his pants on. Well, it's really easy just to cut right up that pant leg, expose that whole leg so you can see it. You can see the deformity, everything, but they're showing pulling traction while the other EMT is supporting the thigh. One thing we like to do, because when you pull, you tend to drag them across the floor, is put like in that lower right one where it says D, put the EMT or the EMR will put their foot up against the patient's foot and keep them from sliding across the room with them as they pull traction. Here shows a nice splint of a knee injury. Knee injuries are fairly common. Just the patella sometimes can dislocate. That little kneecap can dislocate. And you'll position these in the position found. So if it's a straight leg, I hurt my leg, but my leg's straight, well, that's pretty easy. Just put the boards on either side and wrap it together. If it's bent, then you have to immobilize it in a bent position, and this makes it pretty easy just to throw a pillow up underneath there and then keep them in that bent position. A lot of different things that you can use to secure it, but once you secure it, make sure that it doesn't move anymore, because that's the whole reason you're trying to splint it, is to immobilize it. Depending on what their injuries are, if this is isolated, they just kind of turned wrong, they can go on a stretcher. Otherwise, they need to be placed on a backboard. Fractures of the legs, the lower leg, ankle, foot can be immobilized with air splints, cardboard splints. Think about using what's on either the response vehicle or the ambulance rather than trying to makeshift things. Sure, you could take sticks, from the woods and make a splint. Well, if you have something better, use that instead of the sticks from the wood. Ankle and foot injuries, probably the best thing is a pillow splint. It just molds right around the foot and the ankle, and your patients will actually tell you it feels really great. The ankles will swell a lot, and the pillow makes almost like a compression splint. It compresses around it. So you're going to practice all these skills in class. There's a list of skills that everybody will get to practice, so that's kind of fun. And in class, 4 hours is no way that you can really master splinting. So probably the best thing to do is when you go to lab, ask, hey, can I borrow some equipment? Can I borrow a couple of, maybe like a SAM splint and a couple of roller bandages? And can I take this home and practice on everybody at home? Because I guarantee you, you go off once or twice a week to class, and your family's kind of like, wow, I wonder what they're learning. And you come back and tell them stories, but they don't really understand until you say, well, I'll show you. I learned how to do this today. Put a sling and squash on them. You have a pillow at home, wrap a pillow around their ankle, and they're like, well, that's kind of fun, If you have kids, you get them involved in it, and, they appreciate what you're doing. So splinting as well as bandaging, those are true talents, true gifts. And people who really get good at them and master them are the ones that practice them all the time. So kind of think about that. That wraps it up for this part under musculoskeletal injuries. And then I'll continue Chapter 14 for next week with head, neck, and chest injuries, as we'll prepare for doing something we call patient packaging.